Anesthesia for a patient with a cardiac transplant, they may encounter as a elective or emergency procedures. So we need to understand the physiology of the transplanted heart. They might have two techniques, either biatrial or bicaval anastomosis done for this heart transplant, and each have this their own role. In early post-op, these transplant heart is without innervation, so they respond only to the humoral catecholamines. Sympathetic and the chronotropic responses to stress, exercise, and hypovolemia are not seen. So this includes blunting of baroreceptor responses to scopy and intubation. Parasympathetic de-innervation is dominating, so these patients will have a high resting heart rate with a low variability. Afferent de-innervation impacts the vasoregulatory responses by renin-angiotensin activation or pain perception on ischemia, etc. So these patients won't experience a anginal pain. Preload dependent for the augmentation. And they will be having a shift to rightward curve on the Frank-Starlitz curve at rest. Circulating BNP is usually elevated here due to the atrial stretch, and this is due to the need for elevated filling pressures. Even this is present even with the normal hemodynamic parameters. Myocardial metabolism appears normal only. The filling pressures are elevated and never return to normal. This suggests the restrictive pathology. Restrictive physiology. Other than this, the cause can be a donor-recipient size mismatch, increase in the afterload in the form of hypertension, or rejection also can be a contributory cause. Abrupt filling in the left ventricular filling pressures in response to a fluid challenge makes them prone for a pulmonary and systemic venous congestion. And resting coronary blood flow is usually increased due to the absence of sympathetic tone. Abnormal response to the endothelium-derived vasodilators will be seen, like substance P and acetylcholine. But the response to non-endothelium-derived vasodilators are preserved, like adenosine, dipyridamole, etc. Coronary demand-supply mismatch does not result in a ischemia or an anginal pain here. Then most of these patients will be in a normal sinus rhythm only, with an increased refractory period of the SA node. So these patients might have a presentation of heart block, either first degree heart block, or they might have been placed in a pacemaker. The cause of heart block in a post-transplant patient can be like a biatrial anastomosis, which was done originally, then organ rejection or nodal ischemia, and inadequate myocardial preservation, etc. Other than that, clinically, arrhythmias are infrequent, but ectopic beats are common here. Presence of patent ventricular arrhythmias, if present, it shows either a severe acute graft rejection or a allograft coronary disease, which is a common complication. In ECG, we can see two P waves, one from the donor SA node, other from the recipient SA node. Then tachycardia in response to a stress like pain or hypovolemia are blunted, as it depends on the circulating catecholamines. The carotid sinus massage, Valsalva manual has no effect on the heart rate. High risk of developing atrial flutter or the atrial fibrillation in the later years is seen. This is mainly due to the onset of some degree of reinnervation occurring at the later stages of transplant. Coronary autoregulation is actually intact. Immediately after transplant, LV dysfunction due to anoxic injury during the graft transfer, afterload mismatch, or sympathetic support acute withdrawal can be seen. Then the pulmonary artery pressures, pulmonary capillary wedge pressures remains elevated in the first month, then it gets stabilized over a year. Here, these patients will have SVR is usually elevated, so they will have a high normal cardiac output, and the Frank-Starling mechanism shows a rightward. Then complications. These patients will have a rejection. They can present with a rejection or infection or a cancer, and also some comos like diabetic, hypertensive, cardiac allograft vasculopathy, which is a unique form of atherosclerosis in heart transplant patients. And if in pregnant patients, they can present with a preeclampsia. A small word on cardiac allograft vasculopathy. Here there will be diffuse hyperplastic and vision will affect the entire coronary tree, which will have a concentric proliferation. So luminal stenosis in the epicardial branches later. Main sensitive tool is intraosseous ultrasound. to detect this cardiac allograft vasculopathy, and the management differs. Then these patients will be on immunosuppressive therapy with a combination of steroids, calcineurin inhibitors, either cyclosporin or tacrolimus. Nowadays, we have switched over to tacrolimus. Some antiproliferative agents like azathioprine or mycophenolate mofetil. Long-term complications, what we can expect is a chronic diastolic dysfunction, mild to moderate heart failure, infection, immunosuppressive effects. Considerations for anesthesia. Pre-op, we need to maintain a good coordination and communication in between the surgeon and the anesthetist. We need to evaluate mainly the graft function by doing an echo. We need to look for the systolic or diastolic dysfunction. Diastolic dysfunction signifies the signs of rejection. Systolic dysfunction shows the signs of coronary allograft vasculopathy. And we also need to check for the valvular incompetence. These patients have a common presentation of tricuspid regurgitation. Then the rejection status by doing a endomyocardial biopsy. Then coronary allograft vasculopathy by doing intravascular ultrasound or angio. Then we need to ask the functional status of the patient, end organ involvement, and we need to check about the CMV status and also screen for the infection. In ECG, as mentioned earlier, these patients will have a D-wave pattern, or we also can see a pacing spikes if the patient has had an implanted device. If the dependence on this device and the recent arrhythmia episodes and all details regarding this electronic device should be interrogated. If the patient is on the pacing mode, we need to convert to asynchronous mode and anti-tachycardia therapy should be disabled. Intra, we need to keep the defibs ready. Then other than that, lab investigations like complete blood count, renal parameters, liver parameters, electrolytes, and biomarkers. These patients will have elevated BNP levels only. Steroid stress dose can be given if it is an acutely or a recently withdrawn history. We need to maintain a steady state level of immunosuppressant, so we need to continue all those immunosuppressant drugs. And most of all, we need to obtain a high-risk consent in these patients. We need to provide antibiotic prophylaxis, anti-ulcer prophylaxis, and VTE prophylaxis before the procedure itself. And adequate NPO status should be maintained. Intra considerations, in any procedures, we need to maintain a strict aseptic precautions for these patients as they are highly prone for infections. My case is on the herniorrhaphy. All the methods like general anesthesia, regionals, TIVA, or neuraxial blockades, everything can be given. And I choose short GA. Since it is mentioned only herniorrhaphy, I think it might be an open hernia repair, and I'm proceeding with a short GA. General anesthesia can be preferred as there is a possibility of impaired response to hypotension after a subarachnoid block or an epidural. We should not use nitrous oxide as it can suppress the immune system and alter the immune response. Monitors, depending on the patient, depends on the surgery and the patient status. There are a few red flag signs like unexplained weight gain, edema, dyspnea, and sweats, like orthopnea episodes, fever, malaise, rashes, and abdomen pain. These are some red flag signs. So in such cases, we need to go for an invasive monitoring like radial artery BP monitoring, TEE, and TE catheters can also be placed. Here it is provided the patient has no red flag signs and proceeding. We can go for an LMA. I go for an eye gel. Since these patients might have a gingival hyperplasia, bleeding or aspiration risk can on manipulating the airway can be expected. We need to avoid hyperventilation since these cyclosporin tacrolimus have the decreased seizure threshold. Loss of sympathetic response to scopian intubation. So since the denervated heart has a blunted heart rate response to inadequate depth and analgesia, NSAIDs have a bleeding risk, so need to be avoided. Post-heart transplant, this catecholamine response is different from the normal heart. So a few drugs like what we do for brady and hypotensive episodes may or may not react. We don't have an effect of atropine on the transplanted heart. We can go for isoprenaline or adrenaline for a good response in the heart rate. For the hypotensive episodes, dopamine has a reduced effect. Instead, we can go for the isoprenaline, dobutamine, levosimendan, and milrinone. Phenylephrine also has a very good role in increasing the BP, and it does not alter the heart rate. Main goals are we need to maintain the preload, preserve the sinus rhythm, avoid the sudden changes in the afterload, careful monitoring of the intra complications, and we also need to avoid the renal injury by avoiding nephrotoxic drugs. I'll give an IV injection with a propofol dose, sir, and I'll maintain with the sevoflurane. Positioning, regarding the positioning, we need to be careful about the bruises and osteoporosis, since these patients on steroids have the high tendency, and eye paddings and nerve injuries also should be taken care of. Opioids, fentanyl supplementations can also be given, as there are no risks associated. If we have given a muscle relaxant, we can go for attract assisted drug short dose, short acting relaxants. And for the reversal, we need to be careful about the neostigmine, since it can cause a brady and cardiac arrest, as is observed. Sugammadex is a good alternative, but we have used only a short GA. In post-operative care, we need to give a good adequate analgesics, early removal or avoidance of the catheter, drains, or invasive lines. This can eliminate the infection risk, and thromboprophylaxis should be started early. Attention to the preload status and renal functions and infection should be noted. We need to continue the immunosuppressant drugs in the post-op.
Very good. Done a very good job of nicely preparing this answer. Just for the sake of discussion, I would like to ask you two questions. What is the difference between P mitral and this double P wave that you get in heart transplantation?
Sir, it will be typical of two complete waves in transplant. P mitral, it will have an M pattern with which does not touch the baseline, the mid.
Excellent. Very good. The second question is, when you describe the technique, you said you prefer to go for GA. Supposing patient says, I prefer to have a regional. Which regional block is ideal?
We can go for a low-dose spinal or a graded epidural, or nerve blocks, selected nerve blocks, ilioinguinal, iliohypoplastic nerve blocks. Or we can supplement regionals with the tab block after the surgery.
Tab block. Okay. So what is the advantage of tab block? Can tab block be given for a cesarean section?
Yes, sir. It helps the somatic pain control, but the visceral pain control, it needs the supplementation.
It's not there. So hernia without a huge sac and big contents, tab block may be sufficient for because the superficial repair. But if the patient already has a long-standing hernia with a large sac and a bowel protruding out of the as a content of the sac, then patient may have discomfort with the tab block alone. Okay, so these are the two questions that I just wanted to ask you. Otherwise, it is an excellent preparation. You have covered all the points. Anyway, just for